Is that you, Sandra, or is that Laura?
Laura,
Hi, Laura. How are you?
good. So I have to be mute now, no?
Yes, yes,
Okay.
yes. Thank you for opening the meeting. No. Now, actually, if you can see on the top here, it says you are in a practice session. Um, you have to click on that to start the webinar or make me co-host and I can do it, but probably easier for you to do it. Do you see that on the top?
I clicked the start webinar.
Oh, you did.
Yes. So we start.
It's it's still saying you are in a practice session from what I see.
Mm,
Does it say that for you?
he has recorded. Let me see.
So you clicked on the box on the top here and it still says that? Hi, Dr. Mitchell. I think it looks like you're still connecting to audio. I can't hear you quite yet.
Hi, good
Hello.
morning, Sunny. How are you?
I'm well, thanks. I'm Liz.
Liz, nice
Nice
to
to
meet
meet you.
you.
You too.
Is this view okay?
Oh, yeah.
Okay.
Yeah, it is actually. We are, so that's not Sandra, she's out today, but it's Laura who's on her team. Laura, are you able to change it to a webinar or do you want to make me, are you able to make me host and I can do it? Sandra and I kind of practiced this yesterday.
Let me see. Give me 1 second because
Sure.
I click on the top
Yeah.
and then it's supposed to you connect to Dr. Mitchell and you start. Now you want to click the recording this meeting?
So two things. So when I don't know, Dr. Mitchell, if you look at the top of the screen, is there a box that says you are in a practice session?
Yeah.
Yes. So Laura, you have to click on that box at the top of the screen and change it to webinar.
Yes, but I don't know what is here.
You don't see that box?
No, I just
Oh,
Zoom webinar. Let me see. Sandra's here and there.
if you make,
Hello, Sandra. I click in the webinar. I click in the top of the screen, and now it's supposed to click on the start webinar on the top of the screen. I click, but now she says she's not working. Uh, and this is doesn't the practice, doesn't the real webinar, she says.
right.
Liz, do you want me to share my screen once we get going?
Yeah, if you don't mind,
Okay.
that would be great. I think it's
All right.
easier if
Let
you
me
drive your
just,
presentation.
And how long do you want me to talk for?
As
Like 20 minutes?
I
Yeah, I was going to
just
say 20 to 30
assume
minutes is
Okay.
usually good, and that gives enough
Okay.
time
we
for
have this
Q&A
record
and
this meeting to
All
this
right.
computer, continue, and just it. Okay, I will continue.
um nobody can, you might know this already, but nobody can come in until we're actually an official webinar.
Ah,
So yeah, so it won't, hopefully we worked this out yesterday, but it's a new day every day with
yeah.
technology.
Okay, no,
Yeah.
let's get this start.
I'm
When
sure
you
Laura can figure
start,
it out.
when you start here.
So I will
Okay,
introduce you
Okay.
by name, and then you can
Okay.
obviously tell the group about yourself in more depth
I
and
think
then launch into your slides.
Okay.
And then I will do my best from your slides to ask questions that you don't answer or elaborate on. And then I'll monitor the chat for questions as well.
Okay. Sounds great.
Sure.
Thank you.
No problem. Thank you.
Of course.
Okay, Laura, it looks like perhaps we are in full webinar mode. Is that right?
Yes, you're right now.
Excellent. And then I can hit, do you want to record? I don't have permission to record. Looks like attendees are starting to come in. We'll just give it a few, we'll give it a few more minutes before we start. Laura, do you want to give me hosting permission so I can record, or are you able to just push record? There we go. Okay. For everybody that's joining, we'll give folks a few more minutes to come on and start at 12:05.
Liz, would you like me to share my screen right now?
Probably no, if you don't mind waiting. I'll just, because some folks might know me, but probably not. And so I'll just say who I am. So people are like, where's Sandra? I see her name, but who is she? And then I'll pass it over to you. Thank you. Okay, I think we're going to go ahead and get started. Good afternoon, everybody. My name is Liz Burrell-Huss. I am filling in for Sandra today. I've been here a couple of times, and it's always a pleasure to be facilitating the community chat. My role is at Montefiore Health System. I'm in the Bronx, and I'm the Director of Health Equity Programs in the Office of Community and Population Health. So my role has actually a lot of overlap with Sandra's role in Rockland. Very excited to be part of this really important conversation, particularly this month, which is Breast Cancer Awareness Month. Today, we are going to be hearing from Dr. Mitchell, who is the Medical Director of the Breast Center and the Director of Breast Surgery for Montefiore Nyack Hospital. And she's going to be talking to us about new ways to diagnose and treat breast cancer. So Dr. Mitchell, if you welcome, and if you don't mind telling us a little bit about yourself, and then I know you have some slides prepared for us, which we're looking forward to seeing.
Thank you so much. Thank you for having me. It's my pleasure to be here, and I always really enjoy our community chats. Thank you, Sandra, for putting all of this together. And thank you, Liz, as well. Sounds like you guys have very similar overlapping roles at our institutions, which is so appreciated. So I'm a breast surgeon. I specialize in what's called oncoplastics, and I'm here at Montefiore Nyack Hospital. We have an amazing team, including radiology, pathology, medical oncology, genetics. I guarantee I am radiation oncology. I'm forgetting someone at the moment, but it'll pop into my head in a second. So what I've been asked to go over today is breast cancer treatment, specifically touch upon surgery, and then ways in which to hopefully reduce the risk of breast cancer. And I'll start out a little bit by addressing, as you had pointed out, Liz, ways that we screen for breast cancer, and then also diagnosis of breast cancer. So hopefully we get all of your questions answered. And if not, I think we have time at the end for some questions. So let me go ahead and share my screen. And Liz, are you able to see that?
Yes.
Okay. Okay. There we go. So my disclosures. So what we're going to talk about today are the pillars of breast cancer treatment. Those include breast surgery, medical oncology, radiation oncology, genetic counseling and genetic testing. We are fortunate to not only have our own amazing team of genetic counselors and MDs here at Montefiore Nyack, but we also have access to and utilize the really great team in the Bronx at Montefiore as well periodically. So we're very appreciative of that team as well.
Dr. Mitchell, sorry to interrupt you. I don't know if you're advancing slides, but we're not seeing the you're advancing them.
I am not. This is just one slide. Yeah.
Oh, okay.
And I was just asked to abbreviate them into a few slides. So,
sure.
Yeah.
Do you want to put it into the slideshow view?
Is it not in slideshow view?
No, I'm just seeing the list, like how you have it when you open PowerPoint on the left side. And the first slide, your title slide is what is outlined. Interesting.
So on my end, it looks like I do have it in the slideshow view, so I'll try it again.
Interesting. Okay.
So on my end, it says slideshow, but not on your end?
No.
Wow, I am enjoying the slideshow on my computer.
We can see them outlined, but yeah, not.
That's so funny. So now I'm ending my slideshow.
Okay, we'll try again.
Interesting.
I don't know if you have to click on enable editing. I have no idea, but the yellow bar.
Yeah, let me try that. How's that?
Oh, hooray. Perfect.
Really?
Yeah.
Fantastic.
You got it.
Solved it. I love it. Okay. So there we go. So we'll run through these topics. This is basically how breast cancer is treated. So we'll start off, we'll just mention for a couple of minutes how breast cancer is diagnosed. The way breast cancer is diagnosed is by a core needle biopsy, which is a tissue biopsy, typically done with a pretty small needle. And that's usually under mammogram or ultrasound or MRI guidance. And the way the breast cancer is found ideally is when it's so small, it's actually only seen on imaging, whether that be an ultrasound, a mammogram, or an MRI. Which brings into play, and we're just taking this backwards, the importance of breast screening. So the current standard of care for screening for breast cancer is annual mammogram or a yearly mammogram starting at age 40. And we often incorporate an ultrasound into that yearly mammogram, especially for women with dense breasts. It provides our radiologists with more information and oftentimes an easier ability to read that mammogram. So which brings us to the diagnosis of breast cancer, which is what I was asked to talk about today, the treatment. So within the aspects of breast cancer treatment, we're going to start with breast surgery. Breast surgery, in general, we have two options. One is what's called breast conservation or a lumpectomy or a partial mastectomy. All of these are the same thing. And what that means is removing the breast cancer from the breast and leaving the rest of the breast in place. And then we also have the option of a mastectomy, which is removing all of the breast tissue from under the skin. And how we try to do breast conservation or lumpectomies these days as much as possible is to incorporate what's called oncoplastic techniques. And the whole thought process behind that is to try to respect and preserve the breast as much as possible so that we perform the surgery, removing the breast cancer with appropriate margins. So doing a perfect cancer surgery or oncologic surgery while leaving as small of a sign of surgery or a surgical footprint as possible. We now know that we have a tremendous amount of data that's come out in the past few years, which is showing that breast conservation or lumpectomy is actually superior to mastectomy in early stage breast cancer. So this is a big deal. We've known for years and years that they were equivocal, and now we have data that shows that lumpectomy or breast conservation is superior. So what does this mean for breast surgeons? It means that we have the onus of responsibility to really make all effort to have the skills to be able to provide a lumpectomy or breast conservation to patients who need it. A mastectomy is still a choice in breast cancer treatment and is sometimes also used as a prophylactic or preemptive measure to help reduce the risk of breast cancer. A mastectomy, these days, we make all attempts to be able to offer what's called a nipple-sparing mastectomy, which is where the outside of the breast, including the nipple, is left, and all of the breast tissue under the skin is removed. That is a mastectomy. We try to combine that as much as possible with immediate reconstruction. Immediate reconstruction can be an implant. It could also be your own tissue from your own body. We work with several really talented plastic surgeons from the community as well. So we're really fortunate to have the Montefiore Plastic Surgery Group that provides immediate reconstruction for our patients that undergo mastectomy. The procedure of mastectomy has improved markedly over the years as well. We're typically able to perform mastectomies with immediate reconstruction, such as a pre-pectoral implant or implants that are put in front of the muscle. And these patients also go home the same day, which is a game changer, and we really can't take the credit for it. It really has to do with anesthesia, I would have to say, because they're so good these days. But there you have it. So many women at the time of their breast cancer surgery will also have the potential for some form of axillary surgery or a lymph node removed from their armpit. One, sometimes 2 or 3 lymph nodes. That's called a sentinel lymph node biopsy. That also is changing over the years. So thanks to research and data, we now know that not everybody needs surgery in their axilla. which is very good to be able to tailor breast cancer treatment, including aspects of surgery, to the individual breast cancer and the individual person. Genomic profile has to do with additional testing that may be done on the actual tissue that has breast cancer. Sometimes we have that run prior to surgery, and sometimes that's done after surgery. So I mentioned the word oncoplastics. What does this mean? That just means that we utilize techniques and make all efforts to respect the shape and size of the breast. Scars, are scars important? We've done work with our colleagues at Brown, where you would think that we don't need data to support this, but as it turns out, women really do care and are impacted by scars on their breasts. So what we are able to do as surgeons is place scars as often as possible in places where we just take advantage of anatomy. We place them in locations where we know that they will heal very well as possible, and hopefully in locations where they're less noticeable and or they heal very quickly and oftentimes become pretty much not even noticeable after a little while. We know that women can feel effects of surgery, and scars can affect sensuality, sexuality, even how clothing choices. So very simple things become too big of a deal. So we try to minimize that and avoid that as much as possible. We've also learned that patients have time to feel informed and be informed of their breast cancer treatment options. Recent guidelines have also come out that we are really encouraged to get breast cancer treatment started within 60 days. The reality is we're oftentimes able to do that in a much shorter time frame, but that is important for people to know that they have that time frame to feel fully informed and make all of their choices regarding breast cancer treatment. We spoke about nipple-sparing mastectomy. Is that a safe procedure? Yes, it is. How do we know that? Based off of a tremendous amount of research that has been published over the years. And that's a big game changer in the world of breast cancer surgery as well as prophylactic surgery. I know we don't have a tremendous amount of time today, so we have condensed all of medical oncology onto one slide. So an important component of breast cancer treatment besides surgery is the whole field of medical oncology. What our medical oncologists will do is evaluate our patients. And some individuals, depending upon the specific characteristics of the breast cancer that they have and the specific characteristics of their body, may be offered no medication at all. They may not require any medication whatsoever for the treatment of their breast cancer. They may be recommended to take a pill such as a tamoxifen or one of its sisters, an aromatase inhibitor, to help further treat breast cancer, to help treat breast cancer, or to help prevent as a risk reduction measure as well. There are so many types and classes of medications that are available in this current era to facilitate treatment of breast cancer. It's quite impressive. And what that results in is an ability for our medical oncologists, who are amazing, to tailor the treatment to each individual person and the individual characteristics, most importantly, of the breast cancer that they have. So we're no longer in the era where everybody gets the same 1 or 2 or 3 types of chemotherapy and that's it. Everything is just incredibly highly specialized. Radiation oncology is another important aspect of breast cancer treatment. So for the most part, most women will have some form of surgery, some type of medication, and some radiation. All three of those are not necessary for everybody, but for the majority of people, that would be the expectation. The role of radiation is to help reduce the risk of recurrence. It's typically part of the treatment when we do breast conservation or a lumpectomy. Sometimes in the setting of a mastectomy, it is also required. Does everybody get radiation? No. And that's all discussed, as is every component of breast cancer treatment at our multidisciplinary breast tumor boards, which are meetings or conferences which occur on a daily basis at breast centers throughout the country. And the rationale for that is for everybody to go over individual characteristics of each person's new diagnosis of breast cancer to assure that everybody receives the optimal therapy and treatments and everything that they need to treat that specific breast cancer. So back to radiation. It's a very important component of breast cancer treatment. And it has become more tailored over the years. Radiation oncologists are able to deliver radiation in a more specific manner. And also many protocols of radiation have actually decreased in the time frame that is necessary to deliver. So maybe in the past, someone would have been offered, 6, 8+ weeks of radiation, and now they might be a candidate for a much shorter radiation, maybe a week, maybe a couple of weeks. It depends on the characteristics of their breast cancer. Psychosocial support. We know, statistically speaking, that breast cancer, especially early stage, is incredibly treatable these years. In this era, it's a markedly different diagnosis than it was 2 years ago, 5 years ago, 7 years ago, 10 years ago. And we are very thankful for that and very appreciative of that. That being said, it is still important to know that we have tremendous psychosocial support and resources available. Those can be factors such as clinical navigators, support groups that are available, multiple resources within our breast center and all breast centers, hospital-based resources, community-based resources, national and international resources. So there are a variety of resources available for any and all individuals who are going through a diagnosis of breast cancer that they may utilize or not utilize, to their desire. So one of the important components of breast cancer treatment is research. And the reason why breast cancer in general is so treatable these days is thanks to research. So thanks to all of those PhDs and PhD MDs and MDs and masters and bachelors of science and everybody who's been in the lab and in the lab, or whether they're doing whatever type of research that results in advances in the components of treatment of breast cancer is so appreciated, as well as all of the people who have been diagnosed with breast cancer who have participated in trials where maybe they've benefited by getting an extra component of treatment. Anyway, that's a bit rambly, but that's why we are where we are. So we all are incredibly appreciative. So what has research given us? Definite advances in breast cancer treatment. We have medications that are far superior and very specific for the treatment of breast cancer. We have radiation protocols which are more effective and more targeted. We have breast surgery that in no way resembles breast surgery that we did 10, 15, 20 years ago. So that's amazing. Genomic profiling, which is additional, essentially genetic testing on the actual breast cancer itself, that helps guide treatment of the breast cancer. Genetic testing for individuals to see if they are at increased risk for, breast cancer, ovarian cancer, other cancers. and technology, the tools that we're able to use in the radiation oncology office, in the operating room, that allow us to really optimize breast cancer treatment. So last slide that we'll go through right now is on risk reduction. So I was asked, how do we prevent breast cancer? We do that right now by reducing our risk as much as possible. So everybody will use the term, control what you can control. What we can do as individuals is exercise. It does not have to be, you don't have to train for a marathon every week. If you can, get outside for 10, 15, 20 minutes a day and take a walk around your block or wherever you live, take the stairs, increase that movement that your body does every day. And it makes an effort, right? So if you can do that 15, 20, 30 minutes a day, that's fantastic. Eating well, increase the amount of fruits and vegetables. So increase the amount, you don't have to become a vegan overnight, but increase fruits, vegetables, and maybe decrease and eliminate, hopefully, junk food and other food that just really is not that nutritious for you. Don't start smoking, quit smoking, including vaping. Then if you're at higher risk, possibly you're BRCA1 or 2 positive, or you're positive for another gene mutation that's associated with an increased risk of breast cancer, you can be evaluated and consider what's called for chemoprophylaxis. Maybe a medication like a tamoxifen might be helpful in reducing your risk of breast cancer. Genetic counseling, genetic testing, of course, you would have already undergone if you're known to be have a gene mutation, but if you haven't had genetic counseling and testing, that's always available. A prophylactic mastectomy is still a valid option. What we do find amongst individuals who are BRCA1 or BRCA2 positive is that about 50% of women will choose to have a preemptive or prophylactic mastectomies, which is preemptively removing the breast to try to reduce the risk of getting a breast cancer, and about 50% of women won't. Both are good options. So then, what do? We recommend increased surveillance. So mammograms, ultrasounds every year. Maybe we add a breast MRI and, lifestyle optimization, eating well, exercise, all of these things. So the whole key in risk reduction is also early detection. So mammogram, annual mammogram, typically associated or oftentimes associated or accompanied by an ultrasound starting at age 40 and continuing every year is the standard of care recommendation. Examine your breasts. If you notice anything that's different or a change, give your breast surgeon or your gynecologist, your primary care a call, go in and see them. In a clinical breast exam, your doctor will do a breast exam for you to see if they're able to find anything or detect anything. Which brings up a good point during this era where we're hopefully getting out of COVID, or at least the intensity of it. If you haven't had a mammogram, just make your appointment, come in and get it. If you notice a lump or something in your breast, don't waste any energy feeling embarrassed or ashamed or anything. You are not the only one. Just call us, call your doctor, your gynecologist, your primary care, and it's the best thing to do. Just come in, get it addressed, and it might not be, it probably is not as bad as you think it is. So it's a good idea. So about 85% of breast cancer treatment does occur in the community, at community hospitals, at community academic hospitals such as ours. So this picture in the back, which unfortunately you're not able to see too well, is just a really beautiful picture of our community right here, with all of the leaves changing. And then the close-up is a quick snapshot of our hospital. So thank you so much. It's an absolute pleasure to be here speaking with you. And thank you, Sandra, and thank you, Liz, and the rest of your teams. And I'm happy to answer any questions.
Thank you so much, Dr. Mitchell. That was a lot of really helpful information. I think you covered most of the questions that we had, and but just wanted to reflect really briefly on as somebody who just is not very knowledgeable about what you're an expert in. I mean, it's so wonderful and humbling to hear about the strides that have been taken over the last many years in terms of treatment for folks. So it sounds to me like it's something that any cancer diagnosis is scary, but just for folks to understand like the advanced treatment and the personalized treatment that's available now is profound.
Yeah. It's a pleasure to be part of this field of breast cancer treatment and to work with such passionate colleagues, and to witness the benefit that all of our patients, every individual, when they're in a role of a patient, the benefit of all of these advances that they're able to take advantage of. It's very encouraging.
Sure, I can imagine. Yeah. That's wonderful. Just a few questions. Firstly, can you talk about who might be at most risk for breast cancer? And secondly, we know that men can also have breast cancer, but we don't hear a lot about them. So I'd love for you to speak a little bit about men and how they should approach thinking through screening and prevention. But first, telling us what groups might be most at risk.
So if you have breasts, there's a risk of breast cancer. It's not something that in general women should live in fear of. Statistically speaking, most women will not get breast cancer. About 1 in 8 or 1 in 12, depending upon how we group populations of women, will get breast cancer at some point in time during their life. And hopefully it's an incredibly early stage, or a stage 0, a pre-cancer, which is remarkably treatable. And then you just move on with the rest of your life, and that's it. So we know that the risk may be increased if you have a family history of breast cancer, if you have a genetic mutation or a genetic susceptibility to have breast cancer, your risk of getting breast cancer then would be increased. If you've had radiation therapy for one reason or another, like to your head or chest, that may confer an increased risk of breast cancer as well. Excuse me. If you've had a prior biopsy on your breast that has shown some atypia, or perhaps something called LCIS or lobular carcinoma in situ, that may also confer an increased risk of breast cancer. So multiple things can give you an increased risk. We know that obesity or being overweight is a risk factor. We know that smoking is a risk factor. We know that alcohol consumption is a risk factor. So some of those things we're able to control, or at least gain control of, once we're aware of them. And some of those things are just genetic. Mm-hmm. So that's where we're at. A nice thing about genetic counseling and genetic testing is both our genetic team here is quite exceptional. And also I can say firsthand, the genetic team at Monty in the Bronx is also phenomenal. And genetic testing is way more broadly available and accessible these days than it was, a few years ago. As far as men in breast cancer, men can get breast cancer as well. The frequency or the incidence is much lower. I think it's about, less than 1% of all breast cancers diagnosed will be in men in general. And it's about 1 in 800 or 1 in 850 men, I believe, I'll have to double check that, would get breast cancer. So if a male has a family history of, BRCA1, BRCA2, BRCA1, BRCA2, or other genes that confer increased risk of breast cancer, if they have a family history where maybe a dad or an uncle had breast cancer, or a female relative as well had breast cancer, they might be at heightened awareness, you know, to check into the risk level that they themselves might have for breast cancer.
Mm-hmm.
We essentially treat it the same as a once it's been diagnosed, as a female who's had breast cancer. There's less research on treatment of male specific breast cancer, but breast cancer in general in this era is treated per to the specifics of that breast cancer itself.
Mm. That's very helpful. Thank you. I just want to remind all participants, if you have any questions, you can put them in the chat and I will relay them to Dr. Mitchell. You had mentioned stages and stage 0, which I hadn't heard of, but it makes so much sense. I wonder if you could briefly walk us through, which I was probably a complex thing, but the stages of breast cancer, because you hear that a lot, but what does it mean?
So it's an excellent question. What it means is it helps describe the breast cancer in a manner that anyone else who would treat the breast cancer is able to know what the therapeutics would be and what the prognosis would be. So staging of breast cancer entails the size of the cancer itself. If there are any lymph nodes involved in the breast cancer, the grade of the tumor, which is a descriptive that the pathologist would provide for us, and then biomarkers on the actual breast cancer itself. And those are terms that a lot of people will hear or remember, like ER, or estrogen receptor positive, or PR, progesterone receptor positive or negative, and then HER2, HER2 positive or negative. So it's quite interesting when all of those factors are, you know, plugged into an algorithm. Then we can see, you know, something stage 1, 1A, you know, 2, 2A, up to stage 4. So stage 0 is something called DCIS, or ductal carcinoma in situ. And this by definition is a pre-cancer, or in situ in Latin is in-house. So it's cancer essentially that's not technically cancer, but it's right there. So DCIS is treated like breast cancer. You know, another exciting component of breast cancer research is we know that not all DCIS will evolve into stage 1 breast cancer, for example, but until we are able to clearly delineate which DCIS doesn't have to be treated and which DCIS it's very important to treat, the standard of care is to err towards treating all DCIS. But that's another example of you know, all of the research that is ongoing in the world of breast cancer treatment.
And you had mentioned obviously doing self-exams, and if you can, you know, if you find something that doesn't feel right, to check in. Are there other symptoms of breast cancer that folks can look out for or should be aware of?
That's a good question. So the number one would be get your mammogram every year. Number 2 would be also check your breasts whenever, wherever. It doesn't matter how you do your breast exam, but if you feel anything that just in the back of your mind, you're like, that's weird, I don't think that was there before. And keep in mind, the breast undergo regular changes, you know, on a regular basis over the years. So it's quite possible that what you discover may not be breast cancer. It might be something completely normal, but always err towards going in and getting it checked out. I know myself, as well as any and all doctors, would rather you call and come in and get it checked out and it turn out to be nothing than to waste any energy worrying about it, or to let that opportunity go of picking it up quite so early. So I would say the most typical, you know, signs and symptoms for breast cancer would be breast related.
Okay. And you had, I think a related question, you had mentioned, along with mammography for those of us who have denser breasts, you also recommend ultrasounds. That's something I had never heard before. And I'm over 40 now, and have done my mammogram actually at Nyack, because I live in the area. But is that a new recommendation, or can you talk a little bit more about the ultrasound and how that works with the mammogram?
So it's interesting. Many years ago, based off of advocacy for breast cancer screening, an individual in Connecticut actually really fought for the right for women who are undergoing mammograms who are noted to have dense breasts to be told that they had dense breasts and may possibly need an ultrasound to help give the radiologist a fuller picture of the breasts, if that makes sense. And I'm getting the time frame wrong a little bit, but it definitely originated in Connecticut through patient advocacy, a woman who was very passionate about getting this information out. And since then, I believe the majority of states, I'm not sure if it's all 50 states, have a requirement where when women are noted to have dense breasts on their mammogram, that they're told that they may benefit from additional testing, such as an ultrasound. So the mammogram is still a gold standard for breast cancer screening, but it is true that an ultrasound is and can be very helpful for many women, especially with dense breasts. It just affords the radiologist an additional tool to be able to see the breast tissue.
Yeah. That's helpful. Just, I think, 2 or 3 more questions. Thank you. And I don't see any in the chat so far. I think we all, or most of us, classically know, or think we know some of the side effects of radiation and chemotherapy. But I wondered if you could talk about, in particular for breast cancer treatment, what might be some of the consequences / side effects of chemo and surgery. I know you've touched on this in terms of scarring and things like that, but anything in particular?
So nothing we do, everything always has a potential for some kind of a side effect or an adverse event. So the most common things with surgery is, someone will have a scar, and that's where it's not possible to do surgery without them. So we try to place it in a manner that, that will heal the best. With surgery, commonly there will be a little bit of numbness, anytime you have surgery, either the area of surgery or the area of the scar, there will be numbness or change in sensation of that area for a while. And that time frame depends on the individual. But those are pretty typical. With radiation, sometimes men will get what looks like a sunburn, on their skin. And the radiation oncology team is really good. What they typically do is either give women or give them access to creams that are really, really effective at moisturizing the skin and kind of being protective. And that sunburn look or skin changes, that typically goes away. Once in a while, women will note towards the end of radiation that they feel tired. And then they might go to bed a little bit earlier or take a nap, but then that also, their energy level also, they say, goes back to normal. And medications, it depends. Some women will have no complaints whatsoever. Some women, and it just depends on, our bodies are all a little bit different.
Yeah.
And the reality is the medical oncologists are just so great at, if they know that a medication might be associated with a potential for making someone feel nauseated, they will counteract that with a treatment. So in general, most of the people who go through breast cancer treatment, the medications that they get, they handle them really, really well these days. It's a different era, but it can still sometimes be tough.
Mm-hmm. That's helpful. And, obviously you work and you're the director of the breast center. And I know that there are breast centers in different hospitals and academic medical centers. Is that typically the place where folks can go for screening, diagnosis, and treatment, or what are kind of the different options that people have for those kind of three ways to kind of know and then treat breast cancer?
Yeah, that's an excellent question. So yes, they're always welcome. Our breast center is here. We are here purely to serve the community. So, if anyone has any breast issues or questions or problems, that's exactly what we're here for and why we're here.
Mm-hmm.
We are really fortunate at this breast center to have radiology right here in the building, meaning a mammogram and ultrasound right here, which is great. Some breast centers or cancer centers might have their mammogram and ultrasound or radiology in another building right next door or about a block away. But typically, what places will make an effort to do is, if it's not all in the same building, all of the services is make an effort to inform the patient, how to get from one place to the other and to function as a cohesive unit.
Mm-hmm. That's wonderful. I mean, it can be hard to kind of navigate the different parts of the health system. So it's, especially when you're kind of going through a health crisis, it helps to have it all be kind of in one place or close by. Yeah. Wonderful. So obviously you've covered a lot. Is there anything that you think would be helpful for us to know that we didn't cover? Anything else?
I would just encourage, it's been a crazy few years. You can probably say that about many time periods in the history of the world, but, for all of us alive right now, this was a first, this COVID pandemic. So, one of the realities of it is a lot of women, because they typically are running the show, and raising all of the kids and running their families and carrying the burden of the world on their shoulders is make sure it's very, very important just to take the time now. It's not selfish, it's important. It's important for your family, for you to be healthy. And it also sets a really, really great example for your kids, your brothers and sisters, your parents, that taking care of yourself is a priority, and allows you to be happy and healthy, and participate in your life as fully as possible. So, if you've put off a mammogram, don't worry about it. Just call and make an appointment and come in. Nobody will give you a hard time. You are not the only one who has, skipped a mammogram or 2 or 3 for the past few years. If you notice any changes in your breast or a lump or a bump or anything, don't worry about that either. Just call and come in. You're not the only one. So, there's very little in human nature where it's so unusual you would be the only person that would act that way. So, just call and come in.
That is such a helpful and important message for all of us, and particularly women at this time. So thank you so much. And thank you for your fantastic and super informative presentation. It's been a pleasure.
Oh, it's been a pleasure. Thank you so much. And thanks for being here with us today. Thank you.
Yeah. And thank you everybody that participated. And just to know that I know Sandra sends out the recordings to her network. And I actually have spoken to quite a few people who look forward to receiving those recordings so that they can listen in their spare time. So I'm sure we'll have other folks who reap the benefit of the information that you've shared, Dr. Mitchell. So thanks again.
You're welcome. Thank you.
Take care, everybody. Bye-bye.
Bye-bye.